Herr Vorsitzender, vielen Dank. Ladies and gentlemen, I will talk in English because I see that there are a lot of people who might not be well aware of the Croatian language, albeit the slides are in English. I would like to thank the organizers for inviting me, and when Goran and I discussed this some year ago, my participation, my first question, of course, is what is my mission here? And I made it my mission today and tomorrow, especially in the evening hours, to understand what is e-cardiology exactly mean. And then I looked on the website, because we are all literate in internet, and then I found this webpage of the Croatian e-cardiology group, and there are some points there that actually prompted me to choose the catheter ablation of atrial fibrillation as a topic of my talk. And this is the words that are mentioned there as a task of this working group is have to do something with imaging, have something to do with biosignal processing, and with communication. And for me, that spells atrial fibrillation, this being the oldest published EKG of this well-known arrhythmia. Every serious talk on atrial fibrillation begins with a slide like this, but I'm not going to do that because you all know that. But what I've learned yesterday from the talk is that fractals and chaos theory and stuff, they have to do something with these nice images. And when you, this is actually an image that I got from the Google search machine when I put chaos theory in, and this is something I got there, and I see 3 dimensions, I see colors, and I think again, oh yeah, that's catheter ablation of atrial fibrillation. Because why? Atrial fibrillation is all about chaos actually, and as you can appreciate here, probably and probably not. And it worked a little while ago. Anyway, this is supposed to be an echo image of the atrial, of the sinus rhythm with a well-contracting auricula, and this left atrial appendage, and this is a chaos of the atrial fibrillation, which is very well perceived in the EKG. So the chaos that we see there, we all know it's about micro and macro reentry and multiple circuits, and actually we don't know exactly what's happening there. And it's not as simple as this, that we have some 3 types of atrial remodeling taking days to weeks to months to develop. It's even more complicated and chaotic than that. So atrial fibrillation is actually, for me, a model of chaos in the heart. On the other hand, the problem that we have with the treatment is that what I have been saying to patients in my outpatient clinic when we talk about atrial fibrillation is that, unfortunately, I don't have a magic solution for you. And for most part, this is true. The only magical solution that I have for them is thromboembolic prophylaxis. That's the only stuff that works. Everything else, starting with the antiarrhythmic drugs, even this nice intervention, as you will see, is not perfect and is suitable and can help really a selected group of patients. But if you have a patient like this, and this is a class 2AA indication in the new SC guidelines on atrial fibrillation, and that is a patient with paroxysmal atrial fibrillation, a younger guy. For example, our youngest patient was a male, 21 years old, with a shorter history of atrial fibrillation, and typically no structural heart disease, and significant symptoms. And this is very important. You should weigh the symptoms against the risks and benefits of the procedure. This is extremely important in this, again, costly procedure. And we are talking also, we have to talk about costs today in modern medicine, especially in interventional cardiology. And if he or she has failed at least 1, if not 2, medical treatment attempts, then you might have a patient that has a trigger mechanism in the ostia of the pulmonary veins as a probable predominant mechanism, triggering and initiating the episodes of the paroxysmal atrial fibrillation. And in this sense, you might use the catheter ablation, which in a way is actually imitating an old procedure perceived by a certain gentleman from the States, Jim Cox, who introduced the maze procedure then. Maze is nothing else than labyrinths, so you actually try artificially to put some order into this chaos that is reigning in the atria. And what you do, this is actually the surgical procedure, you put some lines and isolate the areas of atrial tissue with the idea that you bring order into the electrical activity of the late atrium. What we do with the catheter is actually shown nowadays. It's shown here. We mainly, oh no, power off, we don't want that. We want the laser point. So we mainly isolate the ostia within the atrium. We don't go into the veins itself. Nowadays we stay in the left atrium and we isolate, putting scars on purpose there, the electrical activity of those that tissue which is in the ostia of the pulmonary veins, preventing the triggers from reaching the left atrium and initiating an episode of atrial fibrillation. And this is your goal. The goal is something like this, and this is shown on a model of three-dimensional imaging that most of us are using now today for this purpose, with very precise anatomical reconstruction, 3D reconstruction of the left atrium, which, as you well know, is a highly variable anatomical variant. So everybody has a somewhat different left atrium, and we have to pay attention to that. And these little red dots represent those ablation points, which then form scars and isolate this electrical activity. Talking of imaging, and then again, this is the keyword from the e-CARDIOLOGY work group. We need, of course, imaging, and I'm just showing here as an illustration an example of a 3D reconstruction. You can do it by CT, you can do it by NMR, but it helps greatly in advance to know what you are actually getting at. Although you have to recognize that when you do the 3D reconstruction with the navigation system, you actually get a 99% of picture that you have on the CT if you're doing it properly. So it's a very efficient system, but this helps that you know in advance where you are going at. And now I'm just introducing you the E component of this whole system. It's actually a supercomputer, and a supercomputer for 3D navigation has the following principles. It is actually based on a magnetic field that is formed around the chest cavity, the thoracic cavity of the patient, and in this magnetic field you can see the tip of your catheter, and with this tip you can then paint a three-dimensional picture of your left atrium, and at the same time you see the catheters, you see the anatomy, and what is very fascinating, you see it in real time. It's, for me still, I'm doing it for 2 years now, but still very fascinating, without X-ray, and it works really one-to-one in on a second basis. On the other hand, also you get the very interesting electrophysiology data, so you get the intracardiac EKG, and you can retrace your points of ablation, which I will show you in a minute, is very important with this procedure. You have to know where you have been previously with your catheter. So this is just an image showing you how you see the catheter in this system, and this is a 3D reconstruction. This is not the left, but this is the right atrium, and you can put some nice colors there showing the electrical propagation, and again putting some order in a chaos. This is an example of a focal arrhythmia, has nothing to do with catheter ablation of atrial fibrillation. But why do we need this rather also not inexpensive 3D navigation system? We really do need it, and I think we need it for 3 simple reasons. We need it because we need precision. When you ablate and you want to make a line in the heart, you have a couple of problems. These arrows show that actually you have to imagine that with your catheter you are actually drawing a line in the heart. This is like as if you would take your pencil and then somebody would take a piece of paper and move it all the way, all the time, and you're trying to draw a precise line. This is virtually not possible, but with the aid of the 3D navigation you actually get something like this, because you know where you have been, and this system very intelligently calculates for the movements and the distortion that you get there. Again, you see your catheter, you see how the catheter lies within the heart, and very important for you as the operator, but also for the patient, you dramatically reduce the radiation X-ray exposure. After a relatively steep learning curve, you virtually don't need X-ray to perform the ablation. And the whole procedure typically lasts, I'm not the fastest one, but we do it now for 1.5 hours, and we have less than 20 minutes of X-ray, and this is just fluoral. It's not so important because it's not taking pictures. So since we have had this navigation, we are much faster, and this is very much like your GPS in the car. It's almost the same thing. And now I will try to start this movie because I think this is important. I don't know why it's not working here, but it will be working here. Just to show you, it's not a long movie, just 1 minute, to show you how this map is made. I think it's quite fascinating. So you have here You can appreciate here, this is my catheter moving in the middle of the left atrium, and now I'm painting, in a way, a 3D dimensional image of the body of the left atrium. And now in a minute you will see how the catheter goes up in the left upper pulmonary vein, and these are the branches of the left upper pulmonary vein. Then I'm going down, this is the lower left pulmonary vein. In a minute it will all get clearer. So this catheter is actually moving around three-dimensionally. This is now on the right side. Now you already have the left veins and the right veins. This is the view from behind. We are now closing the body of the left atrium, and you, I think at the end, when you are finished, you can appreciate that this image looks very much like the one that I have showed you on the three-dimensional reconstruction of the CT. This is of course fast-forwarded and lasts a minute, but in reality it lasts no longer than 10 to 15 minutes. So it's a very efficient system, and after you have painted this nice picture, you have to put the little red dots. You remember the little red dots, which are the ablation lines, and this I will show you just briefly. This is how we do it. This is the start of the ablation, and in the end you're actually here, and what you want to get at the end is actually this perfect image of isolation of all four pulmonary veins. So returning to my original presentation, so this is the ideal situation that you get at the end. Isolation of the left and the right pulmonary veins, and this is something that you see in the intracardiac electrogram. So typically in those patients, those trigger activity is represented by this intracardiac echocardiogram within the pulmonary veins, and if you have successfully erased those potentials, then this is also an electric endpoint of your procedure. However, of course, and getting to the end of this talk, there is, as always, success, but there is also failure. This is Eduardo, our national player, getting hit by a devious British player. The results are very good. Actually, if you think, you have to imagine and you have to remember how good or not good are antiarrhythmic drugs. There is no drug that is actually more effective than, let's say, 60 to 70% of the cases in preventing the recurrence of paroxysmal atrial fibrillation. So another question is, how do we define the success? But that could be a topic of another separate talk. But on general, we can talk, if you remember the typical patient that I have shown you at the beginning, and this is a paroxysmal patient, you get 80, and after the second procedure, you get up to 90% of long-term success, as defined by freedom of symptoms and even P-wave throughout the EKG throughout the most of the time. This you cannot treat, and this is the list of complications. So again, coming to the point that when you make an indication, you have to be aware of this, and you have to very carefully for the individual patients weigh the risks and the benefits of the procedure. He has to suffer greatly in order, in my opinion, to give him this procedure. Although these complications are really very rare, but they may be serious, and they certainly do depend on the experience of the operator. And in experienced hands, they are close to zero, but nothing is zero in medicine, as we know. So we have to be careful and be aware of this. And the last point that I'm making with the last two slides is that even if you do a nice procedure like I have shown you, you have drawn the little red dots, you have erased the pulmonary vein potentials, everything's perfect, but the chaos does not end there, because you have the problem of the follow-up of those patients. And how do we, first of all, how do we define the success? This is sometimes a problem. How do we monitor with some quality the reoccurrence of atrial fibrillation, or depict the AF burden in terms of simple EKG? This is what Cox has been doing, and so this is why his procedure 30 years ago was set to have a 99% of success. But this is because they did the follow-up, just making one EKG, seeing a P-wave, thank you very much, goodbye. This is certainly not enough. Now you can do some longer Holter monitorings, probably also not enough. And the symptoms, this is very dangerous. The symptoms may be invasive. It is well known that those people, even if they get AFib again, they don't perceive it as, very often they don't perceive it as that symptomatic as before. Is it placebo? Is it really slower? It is much slower. It is a different AFib that they can't, but they are very happy, they are satisfied. But the question remains, do we stop anticoagulation? Because we remember this is the only efficient therapy actually in AFib. So we can help with a loop recorder, but this is not realistic. You cannot put a loop recorder in every patient in order to, monitor 2 episodes of arrhythmia in 6 months. This is not actually feasible, but this is the problem that we have to live with. My last slide, why I think my lecture was an appropriate e-cardiology lecture. I think it was appropriate because in terms of diagnosing, I have shown that AFib is an electrical disorder diagnosed by EKG, that it has a chaotic pathophysiology, that when we talk about one treatment modality, the catheter ablation, it is a fully computerized procedure involving multiple imaging modalities, and in terms of follow-up, there is still, again, some chaos left, and we, again, need some computer tools to follow those patients after the procedure. Thank you very much.
Thank you very much for this very clear presentation. Is there any question? Yeah.
Yeah, I think it was really a very good talk, and I'm very glad that you restricted the indication of AFib to these paroxysmal patients. We all know that patients with persistent AFib, over the long shot, they will have atypical atrial flutter and all these complications. And I wonder, in your experience, how many of all patients presenting with AFib in your hospital, how many patients fulfill these criteria so that you would do that?
Well, I don't have the exact percentage, but I can tell you the numbers. We are, of course, our numbers of these procedures in Croatia are very low. I think in the last 1.5 years, there are only 3 centers doing this, and we have less than 100 patients, so it's a very limited experience. I have currently some 50 patients on my, let's say, list that I plan to do that fit this criteria, paroxysmal, young, etc. So I don't have the percentage, but enough.
Okay. So you are not performing this ablation for persistent AFib patients?
I've done a couple of cases where I thought it were, again, those were younger patients, for some time in AFib, by definition persistent, but with normal left atria and no structural heart disease, and the success rate was around 70%.
So if you have a patient...
But I think, in other words, I think there are patients also with persistent AFib that might be the candidate, but it's not the paradigm example of indication.
If you have a young patient, totally asymptomatic,
yeah.
With persistent AFib, what are you
prescribing? How old?
Young patient, 30 years.
Good question. I would ablate. 30 years, I would ablate.
Okay. You are not happy with persistent forms? I mean, you mean if you repeat the procedure?
It has been disappointed. As you well know, there have been a number of additional techniques in addition to this pulmonary vein isolation that I have shown. Additional lines in the left atrium, searching for some fractionated complexes within the atrium. It has not proven, in my opinion, as far as I know, that it rises the percentage of success. I think it has still been a disappointment. But coming to what you have said, I've been in Germany for quite a long time. I've learned electrophysiology there and so on. We have to differentiate between the symptom-driven or medicine-driven and reimbursement-driven medicine. I think that when we talk about ablating persistent AFib as such, mainly, especially in Germany, we are talking about reimbursement-driven therapy, and this is not good, in my view.
What about cryoablation?
This is new. There are some promising results. It's very attractive because it can be simpler. It's a balloon. You just go in the vein. It's very expensive, much more at this point, much more expensive than this stuff. And on a large scale, still it has not shown that it is better than the classical, let's say at this point, classical 3D ablation. And as I said, if you accomplish the learning curve, you're actually quite quick also with the little red dots. So you're not that much quicker with the Creo, and Creo has, as far as I know, has yet to demonstrate superiority in terms of long-term efficacy.
May I ask another question? Safety. You mentioned side effects. I believe that actually it's not acceptable that after 10, 15 years of AFib ablation, there are no mortality data on the market, on the field.
There are some registry data.
No, but not in as far as randomized trials are concerned. This is in the United States now, 2 or 3 are running, to my knowledge. We should be aware we are doing something and we have no idea what in such young patients, what that means for the long-term survival. But therefore I like a repeated statement that the patient has to be really sick. He has to suffer a lot. He has to suffer a lot until you start to think about ablation. And this is what I like in your attitude. Thank you.
Thank you.